speaker, Dr. Priti, who is also from Pune. She is a consultant neonatologist at Shaishav Children's Hospital.
Good afternoon, everybody. So I'll be talking about on the clinical newborn screening. This is a continuation of the lecture which was given by Dr. Shraddha in the morning. So I'll be talking about 3 aspects of clinical screening. So first from that is the bilirubin, universal bilirubin screening. So 60% of the term newborns, they develop jaundice in the first week of life. Few babies will develop severe hyperbilirubinemia. Pathological levels of jaundice can lead to kernicterus, and early discharge of the baby from the hospital will aggravate the problem. So therefore a pre-discharge bilirubin screening is essential, and identification of babies who are at risk for developing hyperbilirubinemia is essential. So to reduce the incidence of jaundice in the newborn and to prevent kernicterus, there is a need to implement proven preventive strategies. So the pre-discharge bilirubin screening purpose is to identify the babies with serum bilirubin level more than 75th percentile for age in hours, and to track the rapid rate of rise of bilirubin, that is more than 0.2 milligram per deciliter per hour. American Academy of Pediatric guidelines say that all newborns should be evaluated for hyperbilirubinemia before discharge, and the serum bilirubin should be checked in babies who are at risk. Canadian Academy of Pediatric recommend that bilirubin level should be measured by either transcutaneous bilirubin or total serum bilirubin 24 to 72 hours after birth, that is prior to hospital discharge, for all the neonates. So what are the risk factors? Who are the babies who are at risk for developing hyperbilirubinemia? All premature babies, late preterms, siblings with significant hyperbilirubinemia, cephalhematoma or severe bruising, presence of hemolytic diseases such as ABO-RH, G6PD deficiencies, and exclusive and insufficient breastfeeding. Especially this is a very large group of patients, especially if there are difficulties encountered in the breastfeeding. Dehydration, birth asphyxia, and sepsis are another risk factors. So how do we screen for bilirubin? So first is the clinical risk assessment, which includes the identification of the risk factors for the development of jaundice, and second is the clinical examination of the baby for to see for the jaundice. Second is transcutaneous bilirubin and total serum bilirubin. So this is a modified Kramer scale to assess and to plot the progression of newborn jaundice. This is depending upon the demarcated skin zones. The baby's body, it is divided into 5 different zones. Generally the jaundice progresses in a cephalocaudal direction, and jaundice basically, whenever the level is more than 5 milligram per deciliter of the serum bilirubin, then the clinical jaundice, it is evident. So whenever it comes on the face, that is level 1, the score is 1. Here the level of bilirubin is generally 5 milligram per deciliter. 2, it coincides with 10. 3, generally it is 12 milligrams per deciliter. 4 is 15 milligram per deciliter, and 5, which covers the palms and soles. Here this jaundice is generally more than 15 milligrams per deciliter. So this is a rough estimate. Looking at the baby clinically, we can find out like how much can bilirubin level be. Also we have to see for the intensity of the color of the jaundice. Mild lemon yellow color is like mild jaundice, whereas orange color generally it indicates a deeper jaundice. And we also have a transcutaneous bilirubin levels we can be monitored, and we can plot in this chart. So what are the limitations for visual assessment? The assessment of jaundice has to be performed in a well-lit room, preferably in a daylight near a window. There can be inter-observer variability. Absence of jaundice does not mean absence of hyperbilirubinemia, and estimating the degree of hyperbilirubinemia, it can lead to errors. So this is the Bhutani nomogram, which is used worldwide to assess and plot the risk of severe neonatal hyperbilirubinemia. Here we have on the one axis we have the total bilirubin in milligrams per deciliter, and y axis we have the postnatal age of the baby in hours. So we generally do a serum bilirubin or transcutaneous bilirubin, and we plot in this different zones. There are 4 zones given here. High risk zone, which is above the 95th centile. High intermediate risk zone between the 75th and 95th centile. Low intermediate risk zone and low risk zone. So depending upon the level of the serum bilirubin, we have to see in which level the baby falls, and then we have to recommend the repeat bilirubin check has to be done accordingly. So this device is a transcutaneous bilirubinometer. So it is used to measure the transcutaneous bilirubin. This is JM103 by Drager. So transcutaneous bilirubin measurement, it is an adjunct to total serum bilirubin measurement. It measures the yellow coloration of on the bland skin. Newer devices such as BiliCheck and JM103, they correlate well with the serum bilirubin levels. And it is also used to determine if the level of jaundice warrants the total serum bilirubin levels, and serial TCB measurements can be done to see the trends in the bilirubin, whether it is rising or falling. So measurements using the new TCB devices, they are generally within 2 to 3 milligram per 100 ml of the TSB. The usefulness of total serum bilirubin, it generally correlates well with TCB if the levels are less than 15 milligram per 100 ml. And the accuracy and precision for transcutaneous bilirubin is generally less if the levels are more than 15 milligram per deciliter. It can be used in preterm neonates, and it can reduce the number of blood sampling. So what are the advantages of transcutaneous bilirubin screening? It is non-invasive, inexpensive, and decreases the blood sampling, especially very important in late preterm babies. Newer devices such as Drager JM103 BiliCheck, they overcome the limitations of the traditional devices by correcting for the skin melanin content. The traditional devices which were used, generally they used to give erratic readings depending upon the melanin content of the skin of the different races, but the newer devices are really accurate and they coincide well with the total serum bilirubin levels. Only the disadvantage is that it is unreliable during phototherapy. But there are many studies which have been done which again state that after stopping the phototherapy for about 8 hours, again the TCB and TSB, they again correlate very well. So various studies have been done till date which shows a linear relationship between TCB and TSB. The positive predictive value was almost 81%. There was a study which was conducted in China which shows that the p-value was very significant, less than 0.001. So this is another transcutaneous bilirubin nomogram which is used for the prediction of the significant neonatal hyperbilirubinemia. So another study which was done especially in preterm neonates, and this shows that there was a good correlation between the TSB and TCB, and maximum correlation was seen between 33 to 37 weeks of gestation. So here are different parameters in another study, like they show correlation between the total serum bilirubin and transcutaneous bilirubin. Here generally the birth weight, if baby's birth weight was more than 1500 gram, and the gestation, if it was more than 30 weeks, then the p-value was quite significant. So key points from this: the purpose of universal bilirubin screening is to identify the infants with bilirubin levels more than 75th centile for age in hours, and to detect the rapid rate of rise of bilirubin, that is more than 0.2 milligram per 100 ml per hour. Early identification of severe hyperbilirubinemia and allow for evidence-based targeted intervention, and to reduce the preventable cause of bilirubin encephalopathy. Okay, now we come to the second part of our clinical newborn screening. So here we can see a white pupillary reflex. So the idea behind to show this was we have to check for the red reflex in each and every baby. So red reflex testing is an essential component of neonatal infant and child physical examination. It is very essential for early detection of vision and potentially life-threatening abnormalities like cataracts, retinoblastoma, glaucoma, high refractive errors, and other retinal abnormalities. So here we can see in one eye it is normal and other eye it is white. So Absence of red reflex in newborns means that the absence of reddish orange reflection of light from the retina during ophthalmoscopy, which could indicate a cataract or a leukocoria. Red reflex testing, it is done by an direct ophthalmoscope. So here we have to adjust the lens of the ophthalmoscope to 0 or near 0, and then we have to focus the light. The light passes through all the transparent layers of the eye, that is the cornea, aqueous humor, lens and the vitreous humor, and then it falls on the retina and it is reflected back as a reddish orange hue from the retina. But this test has to be performed in a dimly lit room or a darker room. So red reflex is rated normal when the reflections of both the eyes, when viewed simultaneously and alternatively, they are equal in color intensity and no opacities or white spots are seen within both the red reflex area. So this is a normal red reflex, how it is seen. So in this slide, the first picture, it shows a normal reflex. In the second second picture, you can see that one eye shows a normal reflection, whereas the other eye there is lesser. So that is unequal refraction. It can occur in high refractive errors. And the third one shows a white pupillary reflex, which occurs in cataract or retinoblastoma. AAP recommends that red reflex assessment should be done in all newborns before discharge and subsequent health visits. Early detection of vision and potentially life-threatening conditions such as cataract, glaucoma can be done with this. So the key message is that all babies should be examined for red eye reflex before discharge. Any absence of red eye reflex or white pupillary reflex or asymmetry of the reflex should be immediately referred to an ophthalmologist who is experienced in examining babies. And all infants with the positive family history of retinoblastoma, congenital cataract, glaucoma, retinal abnormalities, they should be referred to an ophthalmologist irrespective of the result of the red eye reflex. Okay, so we come to the third part of our clinical newborn screening. Here we check for the DDH, which is the developmental dysplasia of the hip. It refers to a spectrum of pathology in the development of immature hip. The incidence of unstable hip is very large, 1 per 100 cases, but the actual incidence of dislocatable or dislocated hip is 1 to 1.5 per 1000 cases. So what is the etiology and risk factors for development of DDH? So any condition that can lead to laxity of the joint which fails to maintain a stable femoroacetabular articulation can lead to DDH. There can be a combination of hormonal, mechanical and genetic factors. There can be a positive family history in 12 to 33% of the cases. It is very common in females. The proposed theory behind this is that female fetuses are more prone for the maternal hormone relaxin, which increases the laxity of the joint and which can lead to DDH. And it is seen about 16 to 25% of the babies who are in breech presentation. The left hip is commonly affected. This is because the left hip is commonly forced into adduction by the maternal sacrum. So that's why the left hip is common. There are also high rate of association of DDH with other intrauterine molding abnormalities such as torticollis and metatarsus adductus. Any condition where there is decreased movement of the fetus in utero, such as oligohydramnios or large birth weight babies, they can also cause DDH. So DDH is generally asymptomatic in newborns. So unless and until we screen for it, we can't find it. So a thorough physical examination is very essential. The baby should be relaxed during examination, should be placed in a warm and comfortable setting. Baby should be unclothed and the examination has to be done on a firm examination table. And we must also see for associated physical findings such as asymmetric thigh and gluteal folds, limb length discrepancy, that is when the knees are flexed, we have to see for the height of the knees, and also the restricted motion, particularly abduction. two tests which have to be done, very important to ruling out DDH. First is the Barlow's test. This test assesses the potential for dislocation of a non-dislocated hip. Here the hip is not dislocated. There is a potential that it might dislocate, so we have to check for that. Here the examiner first flexes the hip and the knees and then forces the thigh posteriorly in an effort to dislocate the femoral head. In a positive test, the hip is felt to slide out of the acetabulum when the push is relaxed and it is again pushed back into the acetabulum. The second test is the Ottolani test. Here the examiner attempts to reduce a dislocated hip. So here the hip is already dislocated, and so we have to see that it relocates or reduces into the acetabulum. Here the examiner grasps the thigh between the thumb and the index finger, and with the fourth and fifth finger he lifts the greater trochanter or pushes it anteriorly while simultaneously abducting the hip. So in a positive test, the femoral head will slip back into the socket of the acetabulum, and we can, there can be a delicate clunk which is generally palpable or audible. So here we'll see a video. Okay, so Barlow test generally by flexing the hip and knee, and we flex the thigh and knee and then push it posteriorly so that we dislocate the femoral head. And this is the Ottolani test where the hip is already dislocated, and so we are going to reduce it or we are going to relocate it. So we flex the knees and then we push the greater trochanter anteriorly, simultaneously abducting the hip so that the femoral head slips back into the acetabulum. Okay, so once we find that clinically the hips are unstable, we have to confirm it. So how do we confirm it? Ultrasonography is the diagnostic modality of choice for DDH before 4 to 6 months of age, that is before the appearance of femoral head ossific center. It is reliable and accurate in first few months, and the sensitivity and specificity is very 100%, but there can be inter-observer variability in the first 3 weeks. So during 0 to 4 weeks, physical examination is best. That is preferred over ultrasound because there is high incidence of false positive tests during this period. AAP recommends that every newborn undergo a clinical examination, and babies who have findings suspicious for DDH, they should be followed with ultrasound. Radiographs are performed only after 4 to 6 months, that is when the femoral head ossifies. So hip ultrasound is done if there is abnormal finding on any physical examination of the hip, if there is a family history of DDH, if the baby is in a breech presentation regardless of the sex, if there are associated anomalies such as clubfoot or congenital torticollis, neuromuscular conditions, and we also monitor the patients by ultrasound who are being treated with Pavlik harness just to see the detection of the treatment failure earlier. So the key messages are all newborns, they should have a hip examination for DDH before discharge, and babies who have findings suspicious for DDH and with risk factors, they should be followed with ultrasound, and ultrasound has to be done between 4 to 6 weeks. So to summarize, all babies should undergo thorough clinical examination and undergo screening for bilirubin, red eye reflex, and for DDH before discharge. I think most of the hospitals on the discharge card, like most of you are already practicing for, like you all are doing the thyroid hormone before discharge. So you all can include these 3 clinical screening tests on the discharge card, so that there can be a, I mean, if hence they are done, you can just tick it, I mean the baby can go home if all the tests are positive. If not, then we have to screen them further. Okay, thank you.